Hello, Omar. My name's Amy. Would it be okay if I examined you?
Yes.
Make a general inspection of the patient's demeanour, chest shape, deformity or scars and observe their breathing pattern. Note any unusual effort, accessory muscle use or breathing noise such as stridor. While feeling the pulse, count the breaths for 15 seconds and multiply by 4 for the respiratory rate. Look for equipment such as inhalers or oxygen support and inspect the sputum pot if present.
Could I have a look at your hand?
Check the hands for tobacco staining, peripheral cyanosis and finger clubbing. The latter is most commonly associated with lung malignancy, fibrosis or chronic infection. Look for increased nail curvature longitudinally and laterally with loss of the normal angle between the nail and the nail bed. Assess this by looking from the side. The increased soft tissue distally makes the finger thicker at the root of the nail than at the distal interphalangeal joint, which is abnormal. Nail bed fluctuation is assessed by placing your thumbs under the pulp of the terminal phalanx and pressing on the nail at the base of the nail bed using your index fingers. The nail bed feels spongy if clubbing is present. In some cases, finger clubbing may be accompanied by hypertrophic pulmonary osteoarthropathy or painful swelling of the wrists and ankles. Gently rotate the wrists, asking,
Is this sore?
No.
check for tremor in the hands.
Could you hold your hands out for me? Bend your wrist back.
Watch for about 10 seconds. A coarse flapping tremor is seen when type 2 respiratory failure and carbon dioxide retention lead to encephalopathy. A fine tremor may follow the administration of beta agonists. Look at the neck for accessory muscle use, which can make the JVP hard to see.
Could you open your mouth for me?
Look at the tongue and lips for central cyanosis. To detect lateral shift of the trachea, gently place the tip of your right index finger in the suprasternal notch. Your fingertip should meet the trachea in the midline. This can be uncomfortable, so be gentle. The distance between the suprasternal notch and the cricoid cartilage is normally 3 finger breadths. Any less suggests lung hyperinflation. Downward movement of the trachea with deep breaths is normal. With your fingers in the mid-axillary line and your thumbs off the chest, check chest expansion, which should be symmetrical.
Please can you take a deep breath in?
Watch how your thumbs move. Reduced expansion on one side indicates an abnormality on that side. Check both the upper and lower chest to detect paradoxical inward inspiratory movement of the lower ribs in hyperinflation. Percussion is a way of detecting consolidation or effusions. Percussing over a normal lung or pneumothorax produces a resonant note. Percussion over solid structures, for example, liver, heart, or consolidated lung, produces a dull note. Stony dullness occurs over pleural effusions. Always compare mirror image sites on both sides of the chest for symmetry, as the absolute percussion note varies between subjects. Press the middle finger of your left hand firmly against the chest along the intercostal space. Strike the centre of the middle phalanx with the tip of your right middle finger. Use a loose swinging movement of the wrist. Work down the chest from side to side, comparing left with right.
Please could you take deep breaths in and out with your mouth open?
Next, examine the breath sounds. The breath sounds are usually heard well with the diaphragm, but use the bell if the chest is hairy or if sunken intercostal spaces prevent the diaphragm making good skin contact. Auscultate left and right alternately, comparing mirror image positions. As with percussion, the absolute quality of the sound varies between patients. It is asymmetry you are seeking to detect. Listen anteriorly from above the clavicle down to the 6th rib and laterally from the axilla to the 8th rib. Cover the standard positions systematically and do not forget to listen laterally. Do not ask the patient to breathe deeply for a prolonged period, as this may cause dizziness. Assess the quality and amplitude of the breath sounds and listen for added sounds. Bronchial breathing is a high-pitched breath sound with a hollow or blowing quality, similar to what you hear placing the stethoscope over the larynx during tidal breathing. Bronchial breath sounds are found at the chest wall when normal lung tissue is replaced by solid sound-conducting tissue and the underlying major bronchus is patent. This typically happens with consolidation from pneumonia and over fibrotic scarred lung such as post-tuberculous scarring. You may hear bronchial breathing in thin healthy subjects if you listen directly over the trachea or main bronchi. Now examine for vocal resonance.
Please could you say 111 each time I put my stethoscope on your chest?
111 111.
Over normal lung, the air-filled lung tissue muffles the patient's speech, making it indistinct. Over consolidated lung, in pneumonia for instance, their words are clearly audible. Over an effusion or area of collapse, the sounds will be reduced or absent.
111.
Whispering is not heard over normal lung, but may be heard when the transmission of sound is increased, for example by an area of consolidation. This is called whispering pectoriloquy. Auscultate each side alternately, comparing findings over several mirror image positions.
111 111 111.
Next, examine the neck and chest from behind.
Please could you sit forward for me and swing your legs over the edge of the bed? Could you look straight ahead? I'm going to examine your neck.
Examine for cervical lymphadenopathy. Systematically check each lymph node group. Start anteriorly with the submental and submandibular nodes, then check the upper, middle and lower cervical nodes. Also palpate the posterior triangle along the border of the trapezius muscle and the supraclavicular fossa. The post-auricular nodes are felt behind the ear and the scalene nodes are above the first rib.
Please could you tilt your head to the right?
This helps relax the sternocleidomastoid, allowing you to palpate behind the clavicle.
To the left.
Place your index finger behind the head of the sternomastoid and feel for nodes behind the clavicle and above the first rib.
Thank you.
Inspect the chest from the back, looking for deformities of the spine or chest wall and any scars. Repeat the assessment of chest wall expansion from behind. Place your fingers along the ribs and watch your thumbs to track the motion.
Thank you. Could you cross your arms in front of your chest?
Percuss the chest posteriorly. Folding the arms abducts the scapulae, allowing percussion between the scapulae and the spinal muscles. Stay just lateral to the spinal muscles as they are dull to percussion. Map out any abnormal areas by percussing from resonant to dull. Normal lung and pneumothorax produce a resonant percussion note. Percussion over a solid organ or consolidated lung produces a dull note. A pleural effusion produces a very dull note described as stony dull. Basal dullness due to elevation of the diaphragm is easily confused with pleural fluid.
Please could you take deep breaths with your mouth open?
Repeat auscultation on the back. Again, compare mirror image positions left with right and listen at all the standard positions to ensure you don't miss a localized abnormality. As well as breath sounds, you may hear added sounds. The most common are crackles, wheeze and rubs. Crackles are interrupted non-musical sounds and can result from a number of different pathologies. Concentrate on when they occur in the respiratory cycle and their character, whether fine, medium or coarse. Sometimes added sounds can be due to bubbling in large airway secretions. If you suspect this, remove your stethoscope and ask the patient to cough. Secretions in larger airways will be cleared. Crackles caused by disease of the bronchioles or alveoli will not be affected. Wheeze has a musical quality and implies airway narrowing, for example asthma or chronic obstructive pulmonary disease. Time the sounds in relation to the respiratory cycle. Wheeze tends to be louder on expiration when the airways are narrowest. Inspiratory wheeze implies severe airway narrowing. The loudness of the wheeze is not useful in determining the severity of airway obstruction. With severe bronchospasm, the chest may be silent.
Each time I put my stethoscope on your chest, please could you say 111?
One, one, one. 111. 111.
Remember, increased vocal resonance indicates abnormally good sound transmission through consolidated or scarred lung. The other added sound that you may hear during auscultation is a pleural friction rub. This is a creaking sound similar to that produced by bending stiff leather or treading in fresh snow. It is produced when inflamed parietal and visceral pleural layers move over one another. A rub is best heard with the stethoscope diaphragm. It may be heard only on deep breathing at the end of inspiration and beginning of expiration. A pleural rub is normally associated with pleuritic pain and may be heard over areas of inflamed pleura in pulmonary infarction, vasculitis or pneumonia. If the pleura adjacent to the pericardium is involved, a pleuropericardial rub may also be heard. Pleural friction rubs disappear when an effusion separates the pleural surfaces.
Thank you. Please could you swing yourself back round and lie again on the bed?
Lastly, examine the legs for edema, signs of a deep vein thrombosis or erythema nodosum.
Thank you.